Hello, we are Courtney Conchin, PGY1, Gabrielle Johnson, PGY1, and Dr. Larry M. Bush, and today we will be presenting a case report on Pachymeningitis secondary to an unclassified vasculitis.
Pachymeningitis is an uncommon neurologic entity, histologically defined as fibrosing and an inflammatory process of the dura mater. In most cases, the diagnosis is discovered by MRI, obtained in patients presenting with chronic headaches, frequently accompanied by cranial nerve abnormalities. Occurrence may be secondary to infection, inflammatory diseases, or malignancy, or as an idiopathic hypertrophic condition. In that case, pachymeningitis is rare. It is essential to understand that clinical and radiologic signs are not specific to this diagnosis, and the presence of neurologic features in addition to immunologic, histologic, and infectious workup would be of benefit. Today we describe the case of a 49-year-old woman who is actively being treated for presumed rheumatoid arthritis, poorly responsive to prednisone and Humira. She presented to the hospital complaining of 1 year of progressive frontal parietal temporal headaches, eustachian tube dysfunction, sinusitis, and ataxia. Shortly prior to admission, she developed a left 6 cranial nerve palsy accompanied by papilla edema. Constitutional or systemic manifestations of infection were absent. The remainder of her review of symptoms as well as past medical and surgical history were unremarkable. Pertinent physical exam findings include normal vital signs, left lateral gaze, diplopia, papilla edema, horizontal nystagmus, and ataxic gait. Remainder of physical exam were unremarkable. Pertinent laboratory values as shown in Table 1 include normal CBC and CMP, elevated C-reactive protein, C-ANCA, anti-CCP antibodies, positive rheumatoid factor, blood and CSF cultures grew no bacteria and no fungi. CSF, WBC, glucose, protein were unremarkable. MRI of the brain shown in figures 1 and 2 demonstrated diffuse meningeal enhancement.
Cerebrospinal fluid analysis together with microbiologic studies failed to demonstrate any evidence of bacterial, viral, or fungal infection. In addition, cytologic studies were negative for any signs of malignancy. Based on these findings and the laboratory values mentioned in the table, we concluded that her presentation was consistent with rheumatoid and/or undetermined vasculitis-induced pachymeningitis. High-dose corticosteroid administration significantly decreased her signs and symptoms, and she was discharged on continued course of oral prednisone. Due to the development of what was believed to be a corticosteroid myopathy, her treatment was changed to mycophenolate mofetil. Based on the clinical features in response to treatment, laboratory analysis, and imaging studies, we believe this patient's symptoms can be explained by an unclassified vasculitis. Pachymeningitis is a rare condition characterized by localized or diffuse inflammation of the dura mater with a vast array of causes. The presenting symptomatology depends on the location of inflammation and compression on adjacent structures. Diagnosis is nonspecific and often begins with MRI findings of diffuse meningeal thickening enhanced dura. Serologic and cerebrospinal fluid analysis for autoimmune antibodies and infection can help determine the underlying cause. A dural biopsy may be performed as a last resort. These studies, in combination with extra neurologic features, may help determine the underlying etiology. Treatment depends on the etiology, such as treating underlying infection or malignancy. In the case of autoimmune or inflammatory causes, the mainstay of treatment includes high-dose corticosteroids with or without additional immunosuppressive medications. Not only is our patient an interesting case based solely on the rarity of pachymeningitis, but also the uncertainty of the patient's underlying disorder. We have reason to suspect that perhaps rheumatoid arthritis was an inaccurate diagnosis, and instead the patient has a yet unclassified vasculitic process. For instance, it can be expected that once initiating treatment with Humira, rheumatoid arthritis symptoms improve within 2 to 12 weeks. However, our patient had been receiving Humira for 6 months prior to presentation to the hospital, and yet symptoms persisted without relief. Furthermore, while RA factor and anti-CCP were positive, anti-PR3 was also positive. In addition, the patient endorsed chronic sinusitis and eustachian tube dysfunction within the past year. Given symptomatology, failed treatment with Humira, anti-PR3 positive, and improvement with corticosteroid use, we believe this patient could have granulomatosis with polyangiitis.